So now these are CAKUT anomalies, as I said. What is the clinical significance? Congenital anomalies of kidneys and urinary tract is going to be the full form of this acronym. It is going to be a large group of disorders. It affects not only the kidney, the entire urinary tract, and these anomalies can form a major public health concern. They can account for as much as 40 to 50% of pediatric renal failure cases and as much as 30% of adult onset renal failure is going to be addressed in today's session. So it is going to encompass a lot of spectrum of anomalies, starting from kidneys to the collecting system, the urinary bladder, urethra, and urachal anomalies. Early detection through imaging is crucial for management and preventing the long-term sequelae of these CAKUT anomalies. Okay, so classification is bang on to the point, very easy. Sabse pehle we can address the form. Then we can look at certain fusion anomalies. Then will come the position of my kidneys and then the number of kidneys. So when we talk about renal form, most of these are the structural anomalies, which can have certain functional implications also. How come? Multicystic dysplastic, okay? So persistent fetal lobulations, it's like a normal variant. So it's an anomaly of renal form. Hypertrophied columns of Bertin, Dromedary hump, renal hypoplasia and multicystic dysplastic kidney. So hypoplasia, dysplasia can have both anatomical as well as certain functional implications. Then we come to the fusion anomalies. So if it is incomplete fusion or partial fusion, it can result something like a typical horseshoe kidney or a crossed fused renal ectopia. There also fusion is happening between the two moieties. So cross and fusion. And then there is a rare type of a variant called the pancake kidney. And I happened to see this kidney some in the recent past. So a pancake kidney, a rare variant, but we are going to discuss this also. So these are the three anomalies related to the fusion. Then we have the renal position, a simple malrotation. So for that, we will know what is the normal axis of kidney, when do I have to call it as malrotation, and what are the types of malrotation per se. There are 4 and 5, yes. Okay, then simple renal ectopia and crossed renal ectopia. Then we come to the renal number. There is absent kidney or there is increase more than 2 kidneys in some patients. So blessed to have 3 or more kidneys. So supernumerary kidneys or agenesis of the kidney. So this is the simple kind of visual representation of all the anomalies at a glance. Here we have related to collecting system and then the lower urinary tract. So this was the upper urinary tract to do with the kidneys. Then you have the collecting system, and then in a very systematic way you have the lower urinary tract. So collecting system mein there are going to be anomalies such as a pilocalycial diverticulum, a megacalyx, or a PUJO, ureteropelvic junction obstruction, duplex collecting system, megaureters, retrocable, ectopic ureter, as well as a ureterocele. Very important, they come often as spotters. All of these can be asked in potential spotters or short cases. Then we have lower urinary tract anomalies related to urachus, such as a patent urachus, urachal cyst, urachal sinus, and diverticulum. Okay, so once in every while when we are getting these small pediatric patients, we do get some of the urachal anomalies also. So these are also relevant for our day-to-day reporting. Urinary bladder may, it could be agenesis, duplication, diverticulum, prune belly, as well as cloacal malformation. And then urethra may, we can have anterior and posterior urethral valves or duplication, diverticulum, megalourethra, and certain fistulas, as well as congenital strictures. Related to VUR is going to be congenital VUR. Okay. Now this diagram, again, a very quick revision of the anatomy of the kidney as we are all well versed with. There are 2 main parts. One is the cortex and one has to be the medulla. So in the medulla is, of course, these renal pyramids, but you need to understand that a part of the cortex is going to indent a little bit inside in between these renal pyramids. And when this indentation is going to be more, it can give a hypertrophied column of Bertin. So in between the pyramids, you can have a little bit of cortex trying to insinuate itself in the form of renal columns of Bertin, which can get hypertrophied, which can be a pseudo lesion. Okay, on a USG particularly, it can be a bit difficult to see if it's an RCC or if it's just a hypertrophied column of Bertin. Then, as we all know, we have the renal capsule, we have the minor colices, which are going to form the major colices, which are going to form together the renal pelvis, and then starts the ureter. And then at the level of hilum, we have the renal artery, the vein, and the ureter. So this is from our RSNA article. Again, the same thing, just a quick revision. You can go through this one table of all the CAKUT anomalies. Right. Imaging modalities. Now we come to the various imaging modalities which we have to use, and where and which case which modality is going to be useful. So ultrasound anyway is going to be the first line modality. It is going to be the screening modality. It is very important because a lot of them will be pediatric patients, and definitely radiation exposure is a big concern. So here we will be focusing on a lot of times on an ultrasound, which will be guiding us for management of these cases also. So it's very important and has a huge role to play for CAKUT anomalies. Of course, we know readily available, low cost, non-invasive, radiation free. We can have antenatal and postnatal evaluation. No sedation is required. Limitations would be operator dependency and incomplete visualization of entire collecting system, especially the ureters. The enemy of ureters is the excessive bowel gas, which is especially seen in our pediatric cases. Then we come to an IVU, intravenous urography. So here a very important thing is going to be the renal function. So for renal function, this is going to be really helpful. Also, we can look at the collecting system beautifully. The level of obstruction can be delineated. Okay. Then we come to a VCUG, previously known as an MCU. So here it's very good for the bladder and particularly the posterior urethra. Very important, it's still date, it is going to be the gold standard for VUR and the grading of VUR. Also, follow-up can be done. Okay. And then we have some other studies which have come up for a VUR, such as a nuclear study, nuclear cystography, or an eco-enhanced cystosonography. Because we have the radiation concern, which is huge in cases of our pediatric patients. And if you want to do a follow-up every time, doing an MCU would not be warranted. So we have some studies which can be used as an adjunct for follow-up of these VUR cases. So one of them is going to be sonography based study, which we are going to discuss shortly. Okay, so these were the various conventional imaging. We have an ultrasound, we have IVUs, MCU, we have done all of these day in and day out. We are going to perform these studies. After that, we have this modality which is coming up. It is contrast enhanced voiding urosonography. So short may we can write it as CEVUS. What do we have to know? Just some essential points about this study is definitely it's a radiation-free alternative to MCU. It is very good for the evaluation of VUR. It has a huge role for assessment of VUR. It is very sensitive for even a low grade, like a grade 1 VUR also. It's pretty sensitive. It is also going to give a lot of information about the urethral anomalies, such as PUV, and has a very good diagnostic accuracy. Okay, so this is another study you can just keep in mind when they ask you as a long question on CAKUT. Definitely you have to write about all the modalities. So you should be mentioning a CEVUS. You have to write what are the important indications. Is VUR, urinary tract infection, as a follow-up imaging for VUR post-surgery. And it is also very good for urethral anomalies. It is having a good diagnostic accuracy. Now, there are a lot of videos on YouTube if you want further detailed assessment, if you want to know in more detail about this particular study. And this is one video particularly which can tell you about the technique and all the materials, all the catheters, all the different saline, what kind of contrast media that you will be needing for a CEVUS. Okay. So at the end of the class, first let me go through all the important stuff. At the end of the class, if you guys want a little more detail on CEVUS, we can do in short, we can discuss about the technique of doing a CEVUS. Otherwise, this is a link, this is a video that you can anytime refer to. A really good and short video where you can see how is the technique of CEVUS, how is it performed in real life. Okay. Then definitely we have the cross-sectional imaging, that is CT and MRI. So what is going to be the specific role of CT and MRI in our CAKUT evaluation? So one is going to be whatever on ultrasound the finding has come, you can definitely confirm your findings of ultrasound. Collecting system and vascular anatomy. Lot of times ectopic kidneys, horseshoe kidneys, cross-fused ectopia, they are associated with a lot of vascular variants also. And before you go on for any kind of surgical assessment, you have to definitely do a complete road mapping of the vasculature. So for that vascular anatomy, for looking at the collecting system, so collecting system ke liye it is going to be the CT urography or MR urography. Very good for the collecting system. Detection of certain complex malformations. Okay, because a lot of these anomalies can be associated with certain skeletal anomalies, with certain extra renal manifestations also. So for that, CT and MRI is going to give you a holistic overview. And then early identification of complications. So what are important complications such as calculi, infection, development of masses, which can be done with the CT and MRs. So what is the role of MRI per se? It is going to be one of the preferred modalities because there is no ionizing radiation. It is having a superior soft tissue and contrast resolution, important for evaluating associated spinal anomalies as well as complex anatomy wherever you need to delineate. Okay, so this was about all the imaging modalities at a glance. Now, we are going to start with the renal anomalies. The first is going to be the renal form-related anomalies. So here, there are a lot of important anatomical variants. So especially if you're a first year and you have started to report your abdomens and KUBs on ultrasound, so you just have to prevent from over-diagnosing, okay? You cannot be giving a hypertrophied column of Bertin as an RCC, definitely. So this is very important so that we are not over-diagnosing things, right? We need to have a very clear concepts about these normal anatomical variants which are related to our kidney. So the first one and very common is going to be persistent fetal lobulation. What are these? So actually your kidney is formed by a lot of lobules and then together they fuse together, right? And you get a smooth outline at the end. However, if this fusion process is a bit delayed, you still get these small indentations between the individual pyramids, between the individual chelices. So that is persistent fetal lobulation. You have indentations in the renal outline between the medullary pyramids. So the key word over here, very, very important, is between the medullary pyramid. This is one of the biggest way to differentiate it. The kidney is going to show normal echogenicity. Okay, so kidney is going to show a very normal echogenicity. The ecotexture is normal. The CMD, that is corticomedullary differentiation, is well maintained. The vascular distribution, everything is normal. It is going to be absolutely isodense and isointense on CT and MRI respectively. Similar contrast enhancement like the cortex. So there is no renal significance, but a very important mimic can be renal scarring and sometimes renal tumors. Okay. So we have this table, which is going to make our life very simple, just full on concepts. So fetal lobulation versus renal scarring. Before that, I can show you an image also. So here you see every time there is a pyramid, between the pyramid, this indentation is present. So these are the persistent fetal lobulations. So a very important mimic is going to be renal scarring. And how are we going to differentiate it? So this is normal, physiological sometimes, okay, a variant. And that is all the time, any time you get renal scarring, it's pathological. So here the contour of the kidney will have only these smooth indentations, whereas here it will be very irregular, it will not be smooth. Location pe you have to remember that this is between the medullary pyramids, and this is overlying the medullary pyramids, overlying the calyces. Here, calyces are normal. Here, there can be calyceal clubbing, and dilated calyces can be there, because a lot of time the renal scarring is the end stage healing progress. We know healing by fibrosis. So this is this healing by fibrosis. So chronic vesico-ureteric reflux, chronic obstruction, chronic nephropathy when it sets in. So the healing occurs by this scarring. So most of the time, the calyces will not be normal. They will be dilated or clubbed calyces. It may be related to a chronic UTI or a vesico-ureteric reflux, which results finally at the end with the renal scarring. VUR, it is not associated, and this is strongly associated. So anytime you see renal scarring, you have to be on the lookout to demonstrate a vesico-ureteric reflux in that patient. Now I will show you some more images for this. So this is again a real case where you can see every time between this renal pyramid, this indentation is happening. So between the pyramids is normal. However, if you see this case, here the cortical scarring has happened. It is overlying the pyramid. It is overlying these calyces. Plus, there is cortical thinning. This is the normal kidney. You look at the cortical thickness over here, and here the involved segment, there is severe cortical thinning. You look at the calyces. Normal kidney is showing these calyces, and the affected kidney is showing abnormal, not only dilated, but also clubbed and blunted kind of calyces. So this is a case of renal scarring, and this is a case of persistent fetal lobulations. Now, another important variant, as we discussed, was the hypertrophied columns of Bertin. So this is just focal cortical hyperplasia with hypertrophy of the renal cortical tissue, which is going to insinuate between the renal pyramids. Again, isoechoic, isodense, isointense to the normal cortex, showing absolutely normal contrast uptake like the surrounding renal parenchyma. So here a very important mimic can be various renal masses, but you have to be very clear. You have to rule out as much as possible. You can do this hypertrophied columns of Bertin before giving the diagnosis as a renal mass. So we can have a look over here. This is how this renal column of Bertin can show hypertrophy and can indent. It can look like a renal mass. And then in a real case also, this is how it is going to appear. So very simple thing, if you're doing a Doppler, you have to, if you're doing an ultrasound, you definitely have to put the Doppler. The kind of vascularity you get here, absolutely same vascularity, same waveform, and same PI, RI values you will get over here. And if it's a mass, more often than not, it is going to show some differential pattern of vascularity, either hypervascular or hypovascular. So this is a hypertrophied column of Bertin. And now we come to the third and the last anatomical variant, which is a dromedary hump. So this is a focal bulge on the lateral side of the left kidney. Everything is important. So if you are making dromedary hump on the right side, so you are actually logically wrong, because it is only on the left side. Why? Because it is a kind of a splenic impression which happens on the lateral contour of the left kidney, a focal bulge near the mid pole or lower pole of left kidney. It is identical to normal renal parenchyma. It is important. Again, here an important mimic could be a renal mass. So let's have a look. This is our dromedary hump. So because the spleen is sitting over here, so just below that you see a focal outpouching, a focal kind of a hump which is present. It's a dromedary hump, and this is a real case showing us. So till here the spleen is sitting. The moment the spleen goes and this little hump comes here. Again, you have to put on the color Doppler. The same pattern is going to be there. So as you see more and more cases, actually, you don't ever have this doubt. So if your seniors are there in second year or third year, they will never have a doubt between persistent lobulations or hypertrophied columns of Bertin or even a dromedary hump. So the more we see these cases, the more visual memory we get registered. Okay.